And this is a cryobiopsy where we see, sorry, here some structures that could be the good cryobiopsy. Some structures that could be seen as cysts, but don't really close. If we take a closer look, we see these cells that are spindle and look benign. And we see also this hemosiderin laden macrophages. I think that's all. Very well. Does it say lamb?
The B is silent.
The B is silent, okay.
Yeah, so that's another, I think this is nice to show the morphologic spectrum of it and show it on cryobiopsy as well.
It sometimes has this, oh, okay, this is not an example, has little prominent, like, nothing.
And the hemosiderin laden macrophages are prominent in this case.
Yes. They say if when cells get into vessels, they make it bleed. That's the explanation for the.
Yeah. Another badly named entity in lung pathology, right?
Yeah.
But very, very useful for the boards, for any kind of exam, RISE exam, boards.
Yeah.
I can change now.
Yeah. And of course, the things to know are HMB45.
Yeah.
Tuberous sclerosis, the association of tuberous sclerosis. Women, pneumothorax, those are the buzzwords.
And it's really uncommon in men unless they have tuberous sclerosis complex.
I have never had an example. I think I never had an example. We received many of these cases because the pneumologists are a referral center of it, but I think I've never seen a case in a man.
No, very rare. Actually, one of the first ones was described by Dr. Aubrey and Myers from Mayo Clinic. And then very, very few. I mean, I think there's just a handful in the whole world. Man. It's extremely rare.
What I saw was a case that had the cysts with the cells and also had pneumonitis, cellular and with granulomas. And I had to say I missed the lamb.
Oh.
I missed the lamb, and I said HP on that case. I still don't know why the patient should have the two things, or I don't know. But it was a prominent pneumonitis, and the granulomas were clear. I still don't know. But when they asked again to review the case, I saw the cysts and the cells perfectly, and I said, how could I have missed this? Probably because the trees don't let you see the whole thing.
Yeah.
So.
Yes.
I guess that's sometimes why it's important to not know the history, right? Not know that it's a man or a woman, right? Just to keep a.
Yeah. Definitely.
And for us, it's not that difficult in pathology. It's very easy to separate Langerhans cells histiocytosis from LAM, but maybe from the radiological point of view, it's not that easy because some cases come like crossed, like saying this looks like LAM, and you see a classic Langerhans cell or so.
I remember distinctly one case where world expert, somebody who writes textbooks and stuff like that, once looked at a clinical conference and said at a CT scan, said, this is a textbook case of LAM. They said, this is a textbook. This is what, you could put that image in a textbook and it would be LAM. And it wasn't. It was Langerhans cell histiocytosis.
Really?
But they need pathologists, right?
They need pathology.
And you need to be very sure of yourself to see that and say, it's impossible. This is not. I would say, come on, I diagnosed wrongly some cases or something. Okay, I changed the.
All right.
This case is a child
Mm.
that comes with a miliary pattern.
What did you say, Irene? Miliary?
Miliary pattern, like little dots in the image.
Yeah.
And they suspect an infection, but it was not as they didn't know what it was. They made a biopsy. It's a surgical biopsy, and you see these tiny things. And when you get closer, you see pretty normal interstitium and these things that are, maybe I can find some laminated ones, are calcified, but you see here some are laminated. And I think you have enough to diagnose this case. Microlithiasis.
Yeah, I get the same.
Math pens.
I'm too slow.
Can I say one thing, like just as an aside? I find it kind of funny when a term of a lung disease has pulmonary in the name.
Yeah.
You know, as if you did something great to figure that out. You know, you're like, this is not just alveolar microlithiasis. It's pulmonary alveolar microlithiasis.
It's a great case.
Like, what are you talking about? Yeah, this is beautiful. I've never seen this.
Yeah.
In a real life case.
No, I've never seen it in real life either.
I have two cases. One transplanted and this case.
Oh.
But it's a very rare thing. It's a very rare thing.
Do they know what causes this?
It's a problem in the cell transporter of calcium in the membrane. I'm maybe not saying it perfectly, but they have some problem in exchanging calcium and they accumulate and do that. And there is a treatment that you can take for a slower test.
Cool. Great case.
Yeah.
This is a patient with colon cancer and nodule in the lung. The points I want to highlight in this case is that it's a very rounded lesion, that it has necrosis in the middle, that the patterns, and unlike the adenocarcinomas we used to see, the pattern is the same in all the lesion, looks the same pattern. And this, it's very dark today. My slides look really dark. The cells are tall with basal nucleus, and I'm going to look for the last feature. This had this garland pattern. It looks like a garland.
Garland, nice.
What's your diagnosis? Submit very well.
Yeah, it's a metastatic colorectal cancer as well. Yeah.
Yes.
Yeah, we call this like dirty necrosis with the luminal necrosis there. Yeah. Which is kind of a weird term, but.
Yeah, this is an interesting. This would be an interesting case for another full.
Oh, definitely.
You know, primary versus met would be a very interesting discussion. But for the spotter point of view, this is a great example. Yeah.
We get this often in frozen. Everybody, you know, they do the FNA, you don't get enough material or so, and then you receive the frozen, and it's easy normally. Later, what I need. This case, this is an autopsy case. We get closer. Let's see, well, the interstitium, we can think it's a bit inflamed or swell has swelling, and in the alveoli, we see a prominent hyaline membranes. What is your diagnosis? DAD, fantastic, in the case of the damage, and the exudative phase. And what is this? What is the etiology of this diagnosis?
I haven't seen one yet. Let's see.
No, you cannot say.
Okay.
I mean, the answer is we don't know. Okay. All the alveolar or the diffuse alveolar damage are the same. Yeah. In this case, I did. This was a case. This was a case where they were suspecting toxicity. We have many autopsies like that. It's an oncology patients, and you have to find out if it's toxicity or an infection, and it's hard because you cannot see many. You cannot prove the toxicity,
right?
And you cannot see some infections or most of the infections. It's teamwork, and that's I'm maybe lucky enough because I haven't it dotted to find the Pneumocystis in the membrane. I'm going to be lucky or not.
Showing the real life experience of looking through these.
Yeah, exactly.
So I should have dotted or marked it
at the left
somehow. Sorry?
But you went past that field. Don't worry.
I cannot spend the whole time looking for.
We believe you, Irene. And then they can be very difficult to find, right? Very difficult to find.
Yeah. Very difficult. Sometimes you have to do more than one. I used to do more than one silver and look it very carefully because it's an important diagnosis to say, because some patients are in trials or things, and then you are going to say a drug is bad only because you missed the bag.
Right.
That's a good point.
Issues. It brings up, is really the pneumocystis the cause of the DAD? How do you know that this is not pneumocystis plus DAD due to something else? It's just, it's a never-ending discussion about etiology.
That's true. You cannot say, but normally if you find if you have the DAD and you find the pneumocystis on top of the membrane, you blame the pneumocystis of that.
True.
As I talked about. It's a lady with a mass, with a lung mass. And the PET, do you call it PET?
PET.
PET. It's unclear, just like always, unclear medicine. And they remove they try to diagnose it, but they remove the lesion, and this is what we find. Okay, do you know what it is?
Yeah.
Perfect.
Sorry, you're too fast.
I think the patient doesn't have a bird, because somebody would say, patient has a bird and there's granulomas here. This is fibrotic HP.
I think she has a bird. She has. Do you want to change your diagnosis because of the bird?
No, we'd like to bring it to the multidisciplinary. I don't look at any biopsies without knowing the clinical history.
So we just published a really interesting case of a lipoid pneumonia. It was actually from a bodybuilder who was injecting this lipid substance into his muscles. and it's called synthol, this stuff, and it actually got into the vasculature, and it embolized to his lungs. So there's a like lipoid pneumonia, but it's all associated with the vasculature and not the airways, because it's
Oh.
like an embolic phenomenon and not.
Yeah.
Matt, what did you say? Who published it?
We just published it. It was a case report from Mayo.
Oh, you did?
Yeah.
Oh, that reminds me of, I was going to say in the other case that silicone injection, people who inject it in their butt for like cosmetic purposes, that looks a lot like that. It ends up in the lung.
Yeah.
And then it looks exactly like, well, not exactly, but very similar to exogenous lipoid pneumonia. And it's not really the same thing, because the material is different and the distribution is different, but the vacuoles can be very similar. Yeah. It's beautiful. This what you're showing now. My favorite finding in all of lung pathology.
Nice.
She's eating the bird's food.
So Sanjay, is that a lentil there, or?
It's a vegetable. It's the kind of old vegetable particle.
I know.
Right? That nobody believes except people who know about aspirin, particularly matter aspirin. Nobody believes it. You show it to them and they'll ask you, did it polarize? Was it birefringent? Yeah. Can you do a stain? How do you know that this is not remote? Like, there's so much skepticism about these things. It's amazing. I've almost decided to give up trying to teach people about this.
I just think it's funny because people often always say they're lentils, and it's like are they all lentils, or is everyone really aspirating lentils? Yeah. Like, do that many people eat lentils?
It's so crazy. You show them a finding, and then suddenly the discussion goes into about what kind of vegetable it is.
I know.
Who cares? Who
cares? This is a very beautiful one, but I have problems with this degenerated stuff, and you start talking about cross-povidone and these things, and I say, could this be cross-povidone or it's something else? I don't know. I find it difficult, and I think that you show so many examples that I think that in America people are taking too many or too much sleeping pills. That's my
what is a lot in America?
I don't get that many cases of that. Or maybe we don't do so many biopsies, but it's
maybe
incredible.
There are not too many obese people in Spain is what might be happening. There's a lot of here obesity, right? Massive obesity, gastric bypass surgery, complications of that, and which is this. And of course, possibly a lot of people aspirating. I mean, I'm not sure that any of that is true, but or like accounts for why we see it. But I do, I do have a low threshold for picking these up,
Yeah.
We do get a lot of this stuff. A lot. I mean, doesn't a week go by when I don't see an aspiration case?
Yeah, we see a fair bit too.
Yeah.
I got an entire sunflower seed the other day.
This is a cryobiopsy of a patient, a young patient with an interstitial. It has an image that looks like an interstitial disease, and it is a biopsy under study. You see the interstitium has inflammation, and the alveoli have also some stuff.
Mm-hmm.
Diagnostic stuff.
AFOP.
No.
No. AFOP like. It's AFOP unless it's AFOP like. Okay, ready?
Ready.
Yeah.
Okay.
I got.
Fantastic. I told you the real story of that biopsy. It was it takes me a while to diagnose interstitial biopsies. So I spend some time on do that, and I see one time and again, and I got this biopsy just before leaving on holiday, and it was like, oh, another interstitial. I looked and I was like, super scared.
Yeah.
It was not suspected, but the patient had AIDS.
Wow.
Huh.
It's not subtle at all.
Notice that a Spanish pathologist has stories about leaving on holiday, and the US pathologists are like, what is a holiday?
What does she mean?
Oh.
I went like that. I went with the bag on and saying, "Oh, I'm going to look if I need more cuts or something of this. When I come back, I'm going to see that." And it was like, "What? calling, impossible, this patient."
Wow.
That's something. And I couldn't. There was no CMB. There are these funny looking sometimes, but I've seen this so many times in transplant patients, and I've done so many. I've thrown away so many CMB stains for just angry pneumocytes.
Yeah.
They can be very, very prominent.
I like that term, angry pneumocytes. I'm gonna put that.
Pneumocytes, also known as COVID inclusions.
The pneumocytes, I tell the residents that these pneumocytes are really angry. Something's happening here. But not CMB.
Hey, isn't that so? I can bet I can take 1 million pictures from this biopsy showing you endothelialitis and like venulitis. It's amazing how people say that. Venulitis, you can't even tell in lung pathology what a venule is.
It's true.
You know, differentiate it from an arteriole, and here people are diagnosing venulitis. It's incredible. Oh, here's a nice GMS.
These are the cysts, not the dots, because the dots apparently are not stained. And in my opinion, I always thought that looked like hematias stained with that. There was look like the red blood cells.
Oh yeah.
That look like red blood cells, but the shape that looks a little bit like that.
Yeah.
I was taught like crush ping pong balls, like those ping pong balls. That's if you crush them.
Yes.
And then
there are a lot of cysts in this biopsy.
Do you see the little dots in the middle, like the intercystic bodies in them?
I saw. I think I saw.
That's supposed to be
Not really, but I saw in this biopsy that.
Wow, that one is really big. There's one in that field. There's one really big form, which makes me wonder what that is.
Yes, it doesn't happen that much with yeasts, but with IFA is the word? Hyphae. They become really big, and you think, oh, it's mucor, and no, it's just aspergillus, and it become inflated. I don't trust much in the shape of those.
Yeah,
I agree.
Yeah,
that's great. Maybe just for the trainees, maybe it's just worthwhile describing how we just differentiate that from histo.
Yeah. Irene, you want to do it?
No. Do it. You do it.
Okay, so for histo, the histo and PCP are about in the same size range. And of course, these black things are GMS positive. So two things help really. First of all, the froth with dots appearance that she showed in the H&E is very helpful because you don't get that in histo. It's not an airspace exudate with dots in it. So that's very helpful. The second is the shape of the, these helmet shaped or crescent shaped, crush ping pong shape are not seen in histoplasma. And the third thing is that histoplasma will show you, if you're lucky, you'll see the narrow base budding, which you don't see in pneumocystis. Pneumocystis doesn't bud. So those three things are very helpful, but size is actually very similar, overlapping.
Isn't histo also in clusters?
Clusters just like this, like they're, they can be clustered close together, but I'm not sure that will reliably tell one from the other.
Yeah.
I think the budding is first of all, the H&E is a very good thing.
Yeah.
Plus the budding, plus the shapes. I think those three. You can also use an immunostain, but I'm actually over the years, I'm not. The immunostain for PCP is very dirty, very difficult to interpret. So I'm not that sure that helps in real life.
I've never used it.
No, we don't have it.
I was enthusiastic about it in the beginning, but I'm beginning to lose my.
Cool.
This is another mass case. It's a lung nodule in a heavy smoker patient. They tend to biopsy more those patients that are heavy smokers because they have a stronger suspicion that the nodules are malignant. We have pretty normal lung here. And we here have not normal interstitium and a lot of things in the middle of the alveoli. Then one to cross one to the other, have funny shapes, like dancing.
Yeah, I like that.
What is your diagnosis? Oh, please. Fantastic. Organized pneumonia.
I'm sorry, I don't make any diagnosis without looking at the CT first.
Oh.
So
after that, reviewing the case, I found this like giant cell with, but I don't know if this is something or not.
So do you think this is explaining the mass that the patient had, or is this just perilesional?
The patient had that's the what we don't. It could explain a mass. It could explain a mass, but this patient really had a tumor.
Okay.
That was obstructing the and creating that. I just sign out as OP, and I think it had also another thing that maybe I can show.
Some necrosis, necrotic debris there. Yeah.
The endogenous pneumonia.
Yeah.
What you get when something is obstructed, no, what it's after is obstructive.
Yeah.
Here, sorry.
So the kind of obstructive picture secondary to the lung mass that they had.
And but necrotic, but I couldn't find the tumor. A tumor here. And I found that funny thing, that's the kind of thing that I would say, is this really something aspirated or not? This kind of, I said, maybe somebody that knows more would have this and say, this is a part of, and I keep watching pictures, DJ Rosen Atlas, for example, but are very non-specific things.
Yeah. No, at least for me, this is not anything.
Yeah, I agree.